In the United States, colon cancer or colorectal cancer is the third most common cancer in both men and women. Yet it's the most preventable type of cancer. Regular screening for removal of growths in the colon called polyps reduces the risk of developing colorectal cancer by up to 90% with colonoscopy. And that's what we'll be highlighting as well, that one of the main modalities for colon cancer screening and colonoscopy is both has the ability to identify early precancerous growths in the colon and remove them at the same time, which is unique to colon cancer screening versus other forms of screening. What common cancer can you prevent with screening? So really with prostate and breast cancer, you're more doing early detection of cancer, whereas with colorectal cancer, as we just mentioned, we're actually attempting to prevent future colon cancer. So that's sort of unique to colon cancer and what we do with colonoscopies. So why is it important? You can prevent, not just detect colorectal cancer with a screening test called a colonoscopy, removing precancerous growths in the colon called polyps reduces the risk of colon cancer, and screening by colonoscopy with polyp removal prevents colorectal cancer before it can start. So this is the power of prevention. And this is what we're discussing, and we'll show some examples, is that everyone essentially after the age of 45 should be screened. If you have a colonoscopy or another form of colon cancer screening, we identify early a polyp and we remove it and prevent a future risk of colon cancer. So the colon and rectum form the large bowel or the large intestine, and this is a description of what that anatomy looks like for you. And during the colonoscopy, we look at the entire inside of your colon, going from the lower portion, which is the rectum, all the way up to the right side of your colon, and evaluate the entire colon, looking for these sort of growths that are in the colon. So it usually colon cancer goes through a sequence, and this is describing what that sequence looks like, where you go from a small benign polyp and slowly and progressively turns into a growth, which is an adenoma, and then can go on to a more advanced adenoma, which is technically a low-grade precancerous growth, and then finally can go on to high-grade precancerous growth, and then onto a colon cancer, colon tumor. So we're trying to arrest this, growth and this spread. So colon polyps, so a polyp is a small clump of cells that are in the lining of the colon. Most colon polyps are harmless, meaning that most of the time when we are performing colonoscopies and removing polyps, these are completely innocuous polyps, and most of them won't go on to form anything more, or likely not go on to form colon cancer, but some will, and that's why it's important for us to remove all of these polyps. So in general, they usually don't cause symptoms. It's very important to do screening because as with other forms of screening, we're trying to detect something that doesn't have symptoms, identify early, and remove those polyps that can prevent future risk of colon cancer. So polyps come in different shapes. So this is an example of what a polyp looks like. These are growths on the surface of the colon. Some of them have a kind of a chicken skin appearance. Some of them look like almost like, I guess you could say, like a lollipop come on a stalk. And then in the bottom left and the bottom right, you could see some of them are more flat, lumpy, bumpy. So with some of the technologies we have with high definition colonoscopes, we're able to see even more subtle ones, like the one on the bottom right, whereas the ones on the top would be more obvious. But all of these are potential examples of a polyp that could go on to form a more advanced colon polyp or a colon tumor in the future. Physicians from our GI Society recommend that screening tests can find precancerous polyps and can be removed before they turn into colon cancer. And we're going to talk a little bit about that. So colonoscopy is the only screening test that allows for both identification and removal of colon polyps. It's called polypectomy. So the removal of polyps prevents up to 90% of colon cancers, and with the appropriate follow-up, the chance of death from colorectal cancer is reduced. So this is a little graphic showing what happens during a colonoscopy. So typically, before the step even happens, you would take a day where you are entirely not eating any solid food, and it'd be clear liquids to help clean out your colon. And then there are several days before that of preparation where you're on a low fiber diet and potentially holding any blood thinners. And then nothing to eat or drink for between 2 to 4 hours before the procedure. And the procedure is done under sedation. And there's this flexible tube, which you're seeing, which is this black structure there that has a camera and light on the front. And it helps us to advance the scope all the way through this area, which we're in right now, which is the sigmoid colon, to an upper part of the colon, and identify these growths that we saw in the prior slides. So what happens once we find a polyp? We're able to use various different strategies to remove it. These are all different examples of polyps. And so you can see that we can use a variety of different techniques. One would be a biopsy or a snare, either cold or hot, and to remove a polyp. It looks like the one on the bottom left most likely was a snare that was used with heat energy. Leaves a little artifact around, which is from cautery, and that shows that we've removed the polyp completely. And so the goal is for us when we're doing these procedures is to remove the polyp completely, so we don't have any residual cells that could, go on to form any precancerous growths in the future. Next. So we're going to go on to talk a little bit about who's at risk for colorectal cancer. So these are general statistics. I hope not to overlap with too much with Dr. Ruggles, but colorectal cancer affects both men and women. So a common myth would be that it only affects men or only affects women, but it affects both. So there's about 5%, approximately 5% lifetime risk, which goes to 1 in 23 lifetime risk for men and 1 in 25 lifetime risk for women. So in 1990, estimates show that people born around 1990 have twice the risk of colon cancer and 4 times the risk of rectal cancer than those born around 1950. So this is a little bit complicated. So some of this may have to do with detection and our ability to detect it with, modalities like colonoscopy and CT scans and so forth. But there is definitely things that are related to our diet, unhealthy lifestyle that can contribute. A lot of the different factors for an unhealthy lifestyle are also risk factors for colon cancer. So these are things to keep in mind, that having a healthy lifestyle also may help reduce your risk of colon cancer. Next. Some factors that further increase risk. So these are sort of our classic risk factors we go over with patients in the office, and when we're talking to them about where their risk, are they average risk or are they high risk? We don't have an intermediate category. It's either average risk or high risk. So that determines when your screening starts. So if you have a family history of colon cancer, colorectal cancer, that would put you at higher risk. Specifically, we're looking at individuals who have first-degree relatives or potentially multiple second-degree relatives in terms of this risk. Family history of precancerous polyps called adenomas. Again, primarily we're looking at first-degree relatives who have this. Smoking is another risk factor pretty much for most cancers. Obesity is certainly a risk factor for colon cancer. And there's some that are less known or less associated, but physical inactivity, abdominal radiation, uterine cancer, ulcerative colitis, and then it's been shown that African American race is associated with a greater risk of colon cancer, and that was actually the first group to start screening at 45, and now all groups are screening starting at 45. So symptoms and colorectal cancer. So what are the signs and symptoms of colorectal cancer? So what we were talking about right now is prevention of colon cancer, and largely these polyps are essentially asymptomatic in the vast majority of cases, but there are some early symptoms that can occur. So most of the time there are no symptoms. This is why screening is important. So never ignore any symptoms. So, sometimes you can see a little bit of blood in the stool, may not think it's anything, but would be something to mention to your primary doctor. So you'd be looking for things like blood in the stool, weight loss, and unrelenting or persistent abdominal pain, significant change in the caliber of your bowel habits. These would be things to look out for. So should you wait until you get symptoms to get checked for colon cancer? The answer is no, as we've discussed. So don't hesitate to talk to your healthcare provider about symptoms, even those that are hard to discuss or share. We talked about some of those additionally would be unexpected weight loss, new anemia, or rectal pain. So get screened. Again, you can feel well, and that doesn't mean that everything's okay on the inside, and that's why we do screening. So what are your screening options? So there's a 1-step versus 2-step. So 1-step is, you can consider it sort of the colonoscopy route, and then the 2-step would be the non-invasive route. The American College of GI guidelines explain the difference between 1 and 2 steps. At the end of the day, the best approach is whatever you're going to get done. It's better to be screened than not to be screened. So the 1-step screening would be colonoscopy. So you just have the test, and then there's no further steps. Again, looking for these polyps on the inside of your colon, using the colonoscopy. So as we discussed at the very beginning, the advantage of the colonoscopy is you can be both diagnostic and therapeutic. So you can both diagnose the polyps and remove them at the same time. And it's the most commonly performed GI procedure in the United States. So again, as we said, we can prevent upwards of 90% of colon cancers by removing polyps, and it provides a great protection against colon cancer and death from colon cancer, most likely as well. So there's a 2-step screening process where you do stool-based tests as well. And so there's 2 primarily that fall into sort of this primary category of what we use to screen. A positive test for either one of these stool-based tests would lead to a colonoscopy. So the first one is called FIT, which is short for a type of test, which is an immunochemical test, which looks for hidden blood in the stool. And this is more sensitive than our historical old cult blood tests. As we said, this is looking for hidden blood. And if you have a hidden blood, that leads to a colonoscopy. The second one is a stool DNA test, and is looking for abnormal DNA markers, which are associated with colon cancer or precancerous polyps. It's more sensitive than the FIT test, but your chance of getting a false positive may increase with age. If the test is negative, then you repeat the stool-based DNA test in 3 years. But if it's positive, the next step would be colonoscopy. The brand name for this is Cologuard. So many of you may have seen commercials on TV for Cologuard. It comes in a little blue box. Your doctor, your primary doctor, or a specialist like a GI provider, or colorectal surgeon can order it, and you basically get a little blue box. You get a kit. You submit a stool sample. You produce the stool sample, and then you send the stool sample back in the mail to a company called Exact Sciences, and then they send the results to your physician or your provider who's ordering the test. And again, we follow this depending on what the result is. Negative, repeated in 3 years for the Cologuard. If it's positive, then you need to have a colonoscopy. So tests for people who cannot have a colonoscopy or FIT and are not candidates for a colonoscopy. So there are a few things. They're not as in vogue, you could say, as colonoscopy, FIT, or Cologuard. And I'll explain a few reasons why. One is CT colonography, and the other one is colon capsules. So, so I guess one is that they're not always reimbursed by the insurance. And the second is that second drawback, unfortunately, for these tests is that you do have to take a bowel prep for both. So with the CT colonography, you drink a bowel prep similar to what you do for a colonoscopy. Then you go to radiology, and they put a little tube in the rectum. They put air into your colon, and they take pictures called a CT scan of your colon, looking for these growths on the surface of the colon. If they're present and there's not availability at the center to do same-day colonoscopies, it has to be scheduled at a future date. And same thing with colon capsule. You take a bowel prep, which cleans out your colon and gives you diarrhea, and then you swallow a blinking pill, and that takes pictures of your colon, looking for these gross polyps. And then if there is one that's present, then again, you have to come back for colonoscopy on a different day. The second one, the colon capsule, isn't as well covered by insurances as well, so that would be another drawback. So again, just highlighting one step versus two step. One step is the colonoscopy route, and we both detect and remove polyps. And then the two step is generally either the FIT or the Cologuard. And if that is positive, then we go on to a colonoscopy. There is something else, which is flexible sigmoidoscopy. And what that is it's a form of I guess you could think of it as a form of partial colonoscopy, where we only look at the left side of your colon. And it's been shown that if there are polyps on the left side of the colon, they're more likely to be polyps on the right side. But if they're not, there's less likely. It's something that's not done as much because we are not seeing the right colon, and a lot of the polyps are in the right colon. If you were just to have sigmoidoscopy, if your doctor was to recommend it, it'd be done every 5 years. But generally, that's not the endorsed test. It's more colonoscopy. So the screening recommendations from the GI societies is that we recommend that average risk individuals. So again, if you remember, we talked about before, that means that you don't have any of those high risk features. There's no family history of colon cancer, colon polyps. You don't have long-standing history of ulcerative colitis. You don't have a personal history of polyps. So those individuals start at 45 until 75. And we're looking for these precancerous polyps called adenoma, removing them, and then reducing the future risk of colon cancer and potentially the future risk of colon cancer death. And then after, from 75 to 85, the decision has to be individualized. So we look at a patient, what their comorbidities are, what their life expectancy is, and decide to continue to screen at that age. After 85, all average risk individuals would discontinue colon cancer screening. Again, we're talking about the screening tests. Most commonly would be FIT or Cologuard, but also sigmoidoscopy, CT colonography, and capsule could be in the mix as well. Recommended frequency for different tests, the primary screening method. So these are maximums. So the colonoscopy in an average risk individual will be done every 10 years. And FIT, that stool test for hidden blood, is annually. If you use one of the alternatives, which is the multi-target, the stool DNA test, aka the Cologuard test, is every 3 years. And sigmoidoscopy, as we mentioned, would be every 5 to 10 years, more likely every 5 years, and CT colonography every 5 years, and the colon capsule every 5 years. There's another test called the Septin9 test, which is a blood-based test to look for sort of DNA or genetic changes, and that one isn't ready for prime time. That is not something that's endorsed by the GI societies at this time. So this is just highlighting the increased risk for African Americans, which has historically been known. Some studies have quoted between 5 to 10% increased risk for African Americans, but that's been variable in different studies. But there's definitely a notable increased risk at a younger age to be diagnosed with colon cancer. And African Americans have had decreased survival compared to other groups with colon cancer. So the ACG, which is our American College of GI, recommends screening African Americans at 45, but actually everyone should be screened at 45. I guess this slide is just highlighting that to make it public knowledge that 45 is the new 50, meaning that we should be screening all average risk individuals starting at 45. So that's the latest that you should start with your screening, and then a maximum of every 10 years thereafter. So talking a little bit about people with increased risk of colon cancer, colon polyps. So if you have a family history of colon cancer, colon polyps, you may need to talk with your healthcare provider to see if you need to be screened earlier. Some genetic testing may be required to determine if you have a risk of colon cancer, if you have a strong family history, especially of relatives being diagnosed at earlier ages. But I guess the most common scenario would be if you had a first-degree relative like mom, dad, brothers, sisters, or kids who have colon cancer or large colon polyps, then you would start 10 years before that affected relative. So if you had a relative who had colon cancer diagnosed at 52, you'd start at 42. That would be an example. So getting screening tests scheduled. So if you would like to undergo colonoscopy, ask your doctor to refer you to a gastroenterologist. And as discussed, I'm a gastroenterologist, and a specialist in disease of the digestive system, perform colonoscopies. And Dr. Ruggles, who's a colorectal surgeon, and colorectal surgeons also perform colonoscopies as well. So that's a way to find a gastroenterologist, and we have our office numbers, and you could call Capitol Health, either the hospital, or you could look us any of the GI providers and make an appointment with one of us, or you can just contact your primary care doctor and they can send a referral. And oftentimes, if you're healthy and you don't have any other medical conditions, you can go through our open access program to have a colonoscopy without being seen. If you have significant medical comorbidities like heart, lung problems, chronic kidney disease that's advanced, immobility, those type of things, you're on blood thinners, most likely you need to be seen before having your colonoscopy. So take control of your health, talk to your healthcare providers about colon cancer screening, and don't put it off. Most importantly, remember to be screened. There's no excuses. They're going to go through a couple of the common ones. Your excuse to avoid colonoscopies, you feel fine. So colon polyps and early colon cancer screening can develop silently without symptoms. Waiting until symptoms occur can mean the cancer is more advanced and less likely to be curable. So you feel good, you still need to get screened. So the excuse is I'm healthy, why get screened? So basically the same thing. Even if you're healthy and you feel fine, you could still be at risk for colon cancer or colon polyp. And the key to being healthy is prevention. So if you can detect something early and remove it, that's going to be to your benefit. No one in my family had colon cancer. Don't be the first. Roughly 5 in 10 people are destined to get colon cancer in their life, even with no family history. So again, like in the general population, there's approximately a 5% risk of colon cancer for everyone. So this is why screening is important. Next. Your excuse is I have no risk factors. The single biggest modifiable risk factor for colon cancer is failure to be screened. So, unfortunately, a lot of times, and Dr. Ruggles will probably say the same thing, is that we see people in the hospital, who have developed colon cancer, and a majority of the time it's that they've never had a colonoscopy. So it's really important to get screened. And the next one is only men get colon cancer. Colon cancer is an equal opportunity disease. Women have approximately the same risk as men for colon cancer. So even if you're a woman, you still need to get screened. Next. So thanks everyone for listening to my talk. I hope you've gained some valuable information. I think later we'll be answering any questions.
All right. I guess I'll just jump in. I'm Ashlee Godshalk Ruggles, and I'm just going to share my screen really quick to kind of add on to what Dr. Saxena was already talking about. Okay, so Dr. Saxena kind of touched on this, so I'm not going to harp on the same thing, but as you can see here, in the top half of the screen, we have new cases of cancer, and then in the bottom half of the screen, we have deaths from cancer. And both for males and females, colon and rectal cancer are the third most common cause of new cases and cause of cancer death. So it's really more common. It's not something a lot of people like to talk about, but I guarantee you know someone who has had colon or rectal cancer. The survival rates are pretty good, which is always good news, especially with all of the advances that we've made. But really kind of the important thing to focus on, they're looking at colon and rectal cancer and they're dividing it into local, regional, and distant spread. So local is when the tumor is just in the colon. Regional is if it's spread into the lymph nodes around the colon, but there's no evidence in the outside other organs. And distant is when it's spread to other organs. Once we get to the point where we have distant spread, the survival rate decreases dramatically. Looking at 5 years, we're going to be right around the 15% mark. Whereas if it's just local, we're looking at 90%. So that's a pretty dramatic change. Regional is definitely lower than local. So if it's in the lymph nodes, then the 5-year survival is about 72, 73%. But obviously, the earlier we catch it, the better people do, which is why we focus so much on getting screened, because the vast majority of patients are not going to have any symptoms until things are fairly advanced. So I like this slide because I think it just gives a very clear visual. The really important thing to know is all of these pretty little colored dots have to do with the incidence of colon cancer at different age groups. So the bottom dots from 20 to 24 years of age, then 25 to 29, and kind of going up by decade as you get higher. And as you can see, the top lines are all curving down. They're all moving in the right direction. But right at about 54 to 55 years old, you see this all of a sudden kind of line that demarcates it. And below that, you see those lines kind of go down, and now they're starting to go back up. And between the ages of 25 and 55, the incidence of colon cancer is increasing. We think the incidence is decreasing in the older ages because patients are getting screened, because people are learning more about colonoscopy and why they need to get it. So this really just goes to show you in the age groups where we're not doing colonoscopy regularly because it's not part of the guidelines, we're really seeing a growth in the incidence of colon cancer, and it's a pretty disturbing trend. So everyone always says, I'll know if I have cancer, I'll have some kind of symptom, I'm so regular, if anything's different, I'll get checked out. 75% of patients diagnosed with colon cancer have no symptoms at all. So the vast majority of people have no idea they have colon cancer. I can't tell you how many times patients come in for their screening colonoscopy, they're just doing what their doctor told them to do, and they're feeling great, and then we find something and they're shocked. But most patients don't have any symptoms. Doesn't run in the family. Dr. Saxena kind of touched on this, but again, 96% of colon cancer is not hereditary, and that's something that's so important. There are so many cancers that are really, really tied to your genetics. Everyone knows about breast cancer and the BRCA gene or BRCA. There are some, genetic syndromes or hereditary things that can lead to colon cancer for sure, but the vast majority of colon cancer is almost 100%. More than 95% of colon cancers have nothing to do with genetics, nothing to do with something that runs in the family. It's just kind of a spontaneous mutation. So how does colon cancer happen? We have these small polyps, and as they grow, they turn into a big, ugly cancer. The way I describe it to my patients is I say, if you had a freckle on your arm and all of a sudden it started growing and looking nasty and big and changing color, you'd go to a dermatologist or your primary care and you'd have it taken off, because everybody knows that that means something bad is happening. The colon polyps are like freckles, and a colonoscopy is basically allowing us to see if there's any of these freckles that are growing and turning into big, ugly things so that we can remove them before they become cancer. Obviously, if we could just look at the inside of our colon, it would make our lives much easier, but the only way to do it is with the colonoscopy. So what are the symptoms of colon cancer? If you're symptomatic, the prognosis does tend to be worse because typically it means things are going to be more advanced. The most common symptom is blood in the stool. 100%, that's what most patients, if they notice anything, are going to say. Other possible symptoms: constipation, abdominal pain, having a blockage, like unable to move your bowels, or pass gas, weight loss, anemia, which is a low blood count. Colon cancers tend to bleed, but again, most of these are not going to be something that you notice until things are really, really far advanced. If you do have symptoms, definitely you should see a doctor immediately and talk about whether or not you should get a scope. So polyps come in different shapes and sizes. You have ones that kind of hang off and are really easy to be removed, and ones that are a little harder. And then obviously as they continue to grow, they turn into a cancer. Is big or worse? This is something that people say to me all the time. Oh, does it look small? I have had patients with 1 centimeter cancer that have spread to the lymph nodes. I have had patients with 10 centimeter cancers that have not spread to the lymph nodes. So really, I mean, obviously we always think if it's bigger, that's worse, but it's not necessarily. So I have colon cancer, now what happens? I really just wanted to kind of touch on what the treatment options are, because it's something that a lot of people ask. But basically we're looking at 3 things: chemotherapy, radiation, and surgery. And those are really kind of always in the conversation for any cancer, but there's really specific circumstances and where we would use one over the other. So surgery is usually first line unless the cancer is metastatic, which means it's spread. So if the cancer hasn't spread, if it's just in the colon, typically you're going to have an operation to have that part of the colon removed with the mass in it. If after we remove it, we remove the lymph nodes around that cancer and we look at them under the microscope, if there is cancer in the lymph nodes, then we would do chemotherapy. Another reason we would do chemotherapy is if the cancer, when we find it, is found to be metastatic or having spread to the other organs. So if there's any evidence of spread, whether it's the lymph nodes or other organs, chemotherapy is going to come into play. Radiation for colon cancer is very infrequent, so really is not typically a treatment modality unless it's kind of growing into another organ or something. Now surgery, a lot of times people think of this big incision and having tubes in your nose and being in the hospital for weeks. Surgery has made a lot of advances in the last couple decades, really, and that is no longer the case. Now, if you look at the picture on the right, you can have minimally invasive surgery where you end up with these tiny scars. It's a much easier recovery, much less painful, and we're able to do colorectal surgery very successfully this way as well. Robotic surgery is my preferred modality. It's a type of minimally invasive surgery, and the robot looks really cool, so I always like to put pictures up there. But basically, those arms all have an instrument inside your body, and I'm controlling those arms to kind of do the surgery. And that's the surgeon sitting controlling the robot. So like I said, surgery is almost always a part of the treatment unless the patient's metastatic on presentation. But if the patient's metastatic but has bad symptoms like bleeding and needing blood transfusion or having a blockage, then surgery still will play a role. Chemo, if it's spread outside the primary site, the lymph nodes or other organs, still though, you know, we're looking at a 15 to 20% 5-year survival. So the numbers are getting better and better, especially as we're developing different immunotherapies and those kinds of things. There are also some newer technologies that we're using to treat metastatic disease, which is really cool. So if colon cancer spreads to the liver, which is one of the primary organs it tends to spread to, interventional radiologists can do a procedure where they put a catheter through the big veins into the liver, and they kind of directly deliver chemotherapy right there, so it's very focused and localized. Or there's a technology where they can put kind of a little probe through the skin after numbing it up into the tumor. They do this all with imaging guidance, and then they kind of zap the tumor from the inside. Radiation, rectal cancer, which, you know, we've kind of been talking about colon cancer, colorectal cancer. Rectal cancer is the bottom part of the colon, and so it's treated differently because the cancer there acts differently. Radiation is typically used in rectal cancer. Colon cancer, not. Radiation and rectal cancer, yes. And these are my references. And that is it. So hopefully that was a good overview. I will say, I know Dr. Saxena went over the statistics. Cologuard, I think, is 92% accurate in diagnosing colon cancer. But I honestly had a patient that I scoped 2 weeks ago who had a negative Cologuard in November, and they have a cancer. So, you know, he unfortunately was in the unlucky 8%, but really, the best way to make sure that nothing's going on or to prevent something from happening is getting your colonoscopy and getting screened.